Okay, thank you, Mohammed. Good evening and welcome everybody to Emirates Society of Internal Medicine Educational Webinars, Rheumatology Waves. Today we have two speakers, Dr. Khalid Al-Naqbi and Dr. Fahad Fazil. Dr. Khalid is Consultant Rheumatology and Chief of Rheumatology in Tawam Hospital. Also, he is Vice President of Emirates Medical Association. And Dr. Fahad is Rheumatology Consultant in Mediclinic Hospital Al Ain. As per schedule, we were supposed to start with Dr. Khalid, but we'll have a slight change. We will start with Dr. Fahad. Dr. Fahad will have to speak about approach to joint pain, and then until like 8:30, and then we will be joined by Dr. Khalid, who will give us a lecture about approach to inflammatory back disease. Dr. Fahad, you may start.
Thank you very much, Dr. Abdullah, and thank you, the Emirates Society of Internal Medicine, for the invitation. So today I'm going to discuss about approach to joint pain. So I chose this topic because this is a common topic which is seen by many different specialties, including internal medicine, GPs, orthopedic doctors. So this is like a general approach. So the objectives of this talk are important points in the history taking, important things in the physical examination, which investigation should we be doing, and just a brief introduction to the treatment of inflammatory arthritis. So history, evaluation of a polyarticular pain begins by ruling out potential musculoskeletal emergencies. So important points to note for the emergencies are like heart and swollen joints, which may suggest infection. So although bacterial infection is more commonly presents with monoarthritis rather than the polyarthritis. Then constitutional symptoms such as fever, fatigue, malaise, weight loss, they are non-specific but raise suspicion of infection or sepsis. Joint pain greater than expected from physical findings, they may be a symptom of a compartment syndrome. And burning, numbness, or paresthesia may suggest an acute myelopathy or radiculopathy or neuropathy. Now, focusing more on joint symptoms in the history. The first is pain. So when we are taking history of pain, we have to look for quality, time of onset, exacerbating or remitting factors, and duration of pain. Now, pain with burning or accompanied by numbness or paresthesia, it suggests a possible neurological cause. The pain in inflammatory arthritis tends to be worse with immobility. And these patients usually have a classical symptom of morning stiffness. So a morning stiffness of like 1 hour or more usually suggests rheumatoid arthritis or polymyalgia rheumatica. Pain of osteoarthritis is actually opposite to that of inflammatory arthritis. It's usually aggravated by motion and weight bearing and is relieved by rest. And then RA, the other thing is whether the presentation is symmetrical or non-symmetrical. The RA is usually symmetrical, whereas osteoarthritis, bursitis, tendinitis, or sprains and strains are usually asymmetrical. Then we go to the duration of symptoms. If the synovitis or pain and swelling of the joints is present for less than 6 weeks, it could represent either a viral arthritis or a systemic rheumatic disease. Whereas if it is longer than 6 weeks duration, the likelihood of it being inflammatory arthritis is more. If the pain is present for weeks, it is less likely to be acute gout or a bacterial arthritis, but it could be chronic gout, systemic rheumatic disease, spondyloarthritis, or bacterial, mycobacterial, or fungal infection. Similarly, when we are taking the history, we have to ask about the functional capacity of the patient, any history of joint injury, risk factors for, or a history of previous infection. Medications are important because some of the medication can cause connective tissue diseases or lupus. Similarly, travel history is important for any infection relating to travel, for example, mycobacterial infection or Lyme disease, etc. So then we have the history about associated symptoms. So this is very important. Weakness usually suggests a neurological or a myopathic disorder. Rash, lymphadenopathy, alopecia, oral and nasal ulcers, pleuritic chest pain, Raynaud's phenomena, dry eyes and dry mouth. They are common in patients with systemic rheumatic diseases. Fever, night sweats, and weight loss. They may also suggest systemic illness. Similarly, always ask patient about any history of psoriasis. It can be a personal history or a family history of psoriasis. Any previous uveitis, so the patients may not come to you with the uveitis, but they may have previous history of uveitis. Inflammatory bowel disease, ask about symptoms of inflammatory bowel disease. The patient sometimes comes to you with the joint pain, but if you dig deep into it, you may find that they are seeing another doctor with inflammatory bowel disease, or they may have symptoms of inflammatory bowel disease which needs further investigation. Similarly, always ask patient about history of back pain. If they come to you with, for example, knee joint swelling, ankle joint swelling, or any other type of inflammatory arthritis, ask them about back pain or stiffness, because sometimes that cannot be the presenting symptom. So high-grade fever usually suggests infection, although a low-grade elevation in temperature may accompany crystal-induced arthritis as well as many systemic rheumatic diseases. Gastrointestinal or genitourinary complaints and recent sexual exposure suggest possible infectious portal of entry and may be associated with seronegative spondyloarthritis, for example, reactive arthritis, psoriasis, or inflammatory bowel disease. The fever suggests a subset of infectious and rheumatic diseases, including infectious arthritis, post-infectious or reactive arthritis, systemic diseases such as Still's disease, lupus, vasculitis, crystal-induced arthritis such as gout or calcium pyrophosphate disease, and other diseases such as cancer, sarcoidosis, or mucocutaneous disorders. So then we go on to the examination of the patient with presenting with joint pain. So it is divided into two parts. One is joint examination, and the second is general examination. So the joint examination is important to establish the presence or absence of synovitis. So how do we do that? So it's a soft tissue swelling, and there is a warmth over the joint line tenderness on palpation. There can be joint effusion and loss of motion. So combining some of these factors, they suggest that there is underlying synovitis of the joint. Then assess the joint for active and passive range of movement. So the reduced active range of movement with preserved passive range of movement, it suggests soft tissue disorders such as bursitis, tendinitis, or a muscle injury. However, if both active and passive range of motions are decreased, then it suggests either contracture or a joint problem, which can be inflammatory or a non-inflammatory joint problem, or a structural abnormality of a joint. The bony enlargement of the joint or crepitus on examination, it suggests usually osteoarthritis. Then acute pain with inability to weight bear, or associated with soft tissue swelling and other signs of inflammation, which is extending far above or beyond the, or above or below the involved joints. That usually suggests septic arthritis or crystal-induced arthritis or fracture. So in this picture, you can see that there are, in the left-hand side, you can see where we have two hands. Well, on a gross look, it may look to you that, oh, this is all normal. But if you have a close look at it, you can see that there is swelling in both the wrists, and then there is a swelling of the MCP joints and also PIP joints in the fingers. On the right-hand side, it is more pronounced, so you can see the first, second, and third PIP joints, which is proximal interphalangeal joints, shows obvious swelling, which suggests underlying synovitis. But that is in contrast to this picture. So in this picture, what you see, yes, there is a swelling on the DIP joints and PIP joints, but these are bony swellings. So these are what we call as Heberden nodes over the DIP joints and the Bouchard nodes over the PIP joints. So they are very typical of osteoarthritis rather than inflammatory arthritis. So then we go on to general examination. So general examination is we have to look for lymphadenopathy, any parotid gland enlargement, oral ulcerations, murmurs, pericardial or pleural friction, or on chest examination, any crackles suggestive of fibrotic lung disease. So then looking for nodules. So here you can see that there are two different types of diseases presenting as nodules. So this one is actually a nodule on the left-hand side. So these are the rheumatoid nodules. Whereas on the right-hand side, you can see this is a typical gout tophi. Then skin lesions. So skin lesions are important because they can give you a clue for the underlying possible cause, which can include infective endocarditis, psoriatic arthritis, lupus, viral infection, Still's disease, dermatomyositis, or vasculitis. And I'm just going to give you some examples in the next few figures. So vasculitis is something which can present to you with multi-system problems. So people can have eye problems, chest pains, numbness and tingling. They can have a peripheral rashes, and they can have ulcers as well. So these are the pictures suggestive of vasculitis. And you can see here the lower limb rashes. This is very much suggestive of vasculitis. Here you see the nail fold infarcts, which usually happens in vasculitis. You can also see them well, not like this, but infective endocarditis has its own appearance in the nail folds. So lupus, so the hands, they are showing here the typical Raynaud's phenomena. So you can see here the whitish discoloration of the finger. Here you can see the typical malar rash, which is lupus associated, and this is the rash on the back for the patient with lupus. But these are some of the pictures. So this one is what we call as a heliotropic rash, which is usually seen in people with dermatomyositis. And in this picture for the hand, you can see here, these are the Gottron papules, which are also seen in people with dermatomyositis. So psoriasis, so relatively more common than the dermatomyositis. So always look at the hidden areas, so which includes scalp. So people may have scalp psoriasis, or they may have psoriasis on the elbows, sometime in the navel area as well. So always ask for and look for the possible psoriasis in patients presenting with inflammatory arthritis. Now, this is the typical salmon pink appearance of the rash, which we usually see in people with Still's disease. So skin examination, very important in people presenting with inflammatory arthritis. So then we have eye diseases, which includes keratoconjunctivitis, uveitis, scleritis, or episcleritis. And here I show you, so this is the people with dry eyes, and you can see some redness here. This is a patient with dry mouth, and similarly, this is the patient with dry eyes. So they can present to you, or they can have these findings on clinical examination. And then again, these are the patients with episcleritis and scleritis, which can suggest the underlying possible autoimmune disease. So then we go to the spinal examination. So spinal tenderness, deformity, and range of motion should always be ascertained in patients with joint pains. And then look for the other things, such as generalized widespread musculoskeletal pain or soft tissue points with other somatic symptoms, which can be such as fatigue or cognitive disturbance, which can be suggestive of fibromyalgia, particularly in the absence of objective joint abnormalities. But at the same time, be aware of superimposed fibromyalgia. So patients with underlying rheumatic disease can have a fibromyalgia in addition to the autoimmune disease. So then we go to the investigation. So what should we be doing in terms of investigations? So request if only clinically indicated. So general investigations are CBC, kidney liver function tests, ESR and CRP. They are non-specific indicators of inflammations. And they are also raised in other conditions such as infections and malignancy. And at the same time, they can be normal in inflammatory arthritis. Then antibody tests identify the exposure to potential pathogens such as group A streptococcus, viruses such as parvovirus, hepatitis B and C, Borrelia or Brucella. And then we go to the more specific auto antibodies. So ANA, which has a high sensitivity but a low specificity for the lupus. And negative ANA in patients with polyarthritis, it essentially rules out the diagnosis of lupus. However, a positive ANA may occur in many rheumatic diseases and non-rheumatic illnesses, as well as healthy individuals. And patients with no clinical feature of SLE is unlikely to have the disease, even in the presence of a positive ANA. And the higher the ANA titer, the more likely that the patient has either SLE or another ANA-associated disease. And then if the patient has a positive ANA and they have the clinical features, then you can request additional serological tests such as double-stranded DNA, ENA, which is extractable nuclear antigen. Then we go on to the rheumatoid factor. So it's done when we suspect rheumatoid arthritis. It has got limited diagnostic value. And you can see that in 50% of the patients with rheumatoid arthritis, rheumatoid factor may actually be negative initially. And approximately 1/3 of patients with rheumatoid arthritis, they remain seronegative throughout their life. It may be positive in other inflammatory or infectious diseases, such as lupus, infective endocarditis, vasculitis, or viral infection. However, a high rheumatoid factor titer have a better predictive value for diagnosis of RA and may also predict poor outcome. Then we go on to anti-CCP, which is anti-cyclic citrullinated peptide antibody. It is more specific than rheumatoid factor for diagnosis of RA and may predict erosive disease more effectively. And the sensitivity and specificity of anti-CCP is around 74% sensitivity and about 95% specificity for rheumatoid arthritis. Then we go on to uric acid. So it is elevated in gout. However, asymptomatic hyperuricemia has a high prevalence in general population, and the finding of hyperuricemia has little diagnostic value. Similarly, normal uric acid levels are fairly common during an attack of gout, including in patients with periarticular involvement. However, if the uric acid is below the lower limit of normal, that would make the diagnosis of gout much less likely. So other tests such as HLA-B27, Brucella, Lyme serologies should be ordered only when the clinical suspicion is high for example, spondyloarthritis, Brucella, or Lyme disease, respectively. So take-home messages on blood test is normal ESR CRP does not rule out inflammatory arthritis. Negative rheumatoid factor does not rule out rheumatoid arthritis. Positive ANA does not always mean lupus. And raised uric acid does not always mean gout. So always interpret blood results in the context of clinical picture. So then we have synovial fluid analysis. So it may be diagnostic in patients with bacterial infection or crystal-induced arthritis. And classification into inflammatory and non-inflammatory category is usually done. And here you can see how to interpret synovial fluid analysis. So white cell count of less than 2,000 usually suggests non-inflammatory. Between 2,000 to 20,000, it's usually inflammatory. More than 20,000, then suspect septic arthritis with predominant neutrophils. And then you can see that the patients who have gout, then you may find active crystals in there. And sometimes people with gout, we can also see more than 20,000 white cells on synovial aspiration. Culture and stain for microorganisms, not always positive, but it may be positive depending upon the organism and prior antibiotic exposure. So next is imaging. So imaging, it's not necessary to do imaging of all the involved joints. In rheumatoid arthritis, hands and feet x-rays are important in chronic cases, not in acute cases. So in acute conditions, radiographs are usually not important and they may not tell you anything. They are helpful in acute conditions like chondrocalcinosis and CPPD disease, but not helpful in rheumatoid arthritis or lupus patients. Sacroiliitis is the earliest radiologic finding in ankylosing spondylitis. However, MRI is more sensitive than X-ray in detecting early sacroiliitis. Images can be helpful in chronic conditions such as osteoarthritis, and you can see here the picture showing joint space narrowing in the knee joint, and here the joint space narrowing of the PIP and DIP joints, suggestive of osteoarthritis. Similarly, here you can see the DIP joint narrowing, extra bone formation, so suggestive of osteoarthritis. Here you see the joint space narrowing, suggestive of osteoarthritis in the hip and severe osteoarthritis of the knees. This picture, now this is a chronic RA, so it shows you the joint erosions in the MCP joints, you can see here, and also in the carpometacarpal joints, and on both the sides. So this is the typical chronic RA radiographic finding. So here you can see the typical finding in gout, which is the moth-eaten appearance of the erosions in gout in hands and in the feet. So in some patients, we do ultrasound examination for subtle synovitis. If clinically you cannot detect synovitis, so basically ultrasound is done to look for any subclinical inflammation, and you can see in these pictures the synovial thickening plus hypervascularity, suggestive of active inflammation, and then there are several grades for it. So ultrasound is important when you clinically cannot find anything, but you think this may be inflammatory arthritis, so you request ultrasound, but it's very much user dependent. Then bone scan is rarely used, and sometime in malignancy, infections, or Paget's disease. And biopsy is similarly rarely used, for example, sometime in diagnosis of tuberculosis, fungal infection, or sarcoidosis. So here is the outline. This is taken from American College of Rheumatology, how to approach a patient with polyarthralgia. So complete history and examination. Then you look for synovitis. If there is synovitis of more than 6 weeks, then suspect the systemic rheumatic disease. If it's less than 6 weeks, it can be viral or rheumatic disease. Then you do a careful follow-up. If there is synovitis, then if there is no synovitis, then you look for any tenderness. Then it can be either fibromyalgia or bursitis or tendinitis, or it can be other soft tissue problem like as osteoarthritis, neuropathic pain, etc. So just a brief couple of slides on monoarthritis. So this is usually common in trauma, infection, crystal-induced arthritis, osteoarthritis, systemic rheumatic disease, and mechanical derangements. And any polyarthritis disorder can also initially present as monoarthritis. And here are some of the causes for acute monoarthritis, which include infection, crystal arthropathies, hemarthrosis, osteoarthritis, systemic rheumatic diseases, tumor, etc. So this is just the brief treatment overview of the rheumatic diseases. So what are our treatment options? So we have non-steroidal anti-inflammatory drugs. Then we have steroids, which can be oral, intramuscular, intra-articular, or intravenous. Then we have DMARDs. So DMARDs are now divided into 3 categories. One is the conventional DMARD, which is methotrexate, azathioprine, sulfasalazine, etc. Then we have biological DMARD. So we have very many different biologicals, and now we have biosimilars as well. So they are different biologicals, including anti-TNF inhibitors, IL-17 inhibitors, IL-6 inhibitors, B-cell targeted therapies, T-cell targeted therapies, IL-23 inhibitors, IL-12, IL-23 inhibitors. And then we have the third category, which is called targeted synthetic DMARDs, which includes 3 molecules at the minute, which is tofacitinib, baricitinib, and ipedicitinib, which are all JAK inhibitors with some differences. Thank you very much.
My turn, I assume, but I need to be given the sharing feature. No sound, Dr. Abdullah. You're muted.
Oh, sorry, Dr. Khalid. Thank you. So for our audience, if you have any question for Dr. Fahad, please share it with us. After Dr. Khalid lecture, there will be time for question and answer. So Dr. Khalid will give us a lecture about approach to inflammatory back disease. Dr. Khalid, you may start.
Okay, so thank you very much for this nice introduction. So I will be talking about approach to inflammatory back pain, so that people will understand the description and start doing some basic history and physical examination and some investigation before sending patients to our rheumatology clinic. So I will do it in questions. So question one, low back ache is very common presentation in primary care and even in general medicine clinics. What is the percentage of spondylitis among those patients? So this is the way we look at back pain. It's soreness or stiffness in back between the bottom of the rib cage and top of the legs. Back pain is the leading cause of occupational disability in the world. So back pain could be mechanical back pain or non-mechanical cause or inflammatory. The mechanical back pain is more common. So basically we're looking at age-related degenerative disc disease, or maybe facet processes. And you can know that from the description and physical examination, and maybe some x-rays. If you have some changes on x-rays, maybe MRI would be better. But you also have muscle or ligament-related injuries. So you always ask about trauma. The non-mechanical causes or inflammatory pain would be 5% of the patients presenting with chronic back pain. Basically, they have inflammatory arthritis, inflammatory back pain, only 5%. And then other causes would be of the non-mechanical would be neurogenic or be referred visceral pain. So refer especially from the colon or appendix or from ovaries in the case of female patients. So this is a big picture of how we look at back pain. So inflammatory back pain, how do we suspect a patient to have inflammatory back pain? Well, these are the usual manifestations, but these are not written in stones. But if patients have more of these characteristics, then they are likely to have inflammatory back pain. So age of onset less than 45, implicating young age of onset. Chronicity, or means chronic back pain lasting 3 months or more. Buttock pain, especially alternating. This is more specific sign than sensitive, which means that you may, if patients have pain in the right side, sometimes the left side, then that's highly suggestive of inflammatory back pain, but again, not confirmatory. Insidious or gradual onset. Morning stiffness, especially significant, lasting 30 minutes or more. Nocturnal pain, meaning pain waking the patient at night. And some patients even wake up and start to move around, so the back pain is relieved. Alleviating factors like physical activity, exercise, or NSAIDs. And I have many of my patients, they are actually housemaids or people in the army. They wake up in the morning with stiffness and pain and becomes better when they start to march, especially in the case of military or police people. Or in the case of occupations that require physical activity, they really become better when they start to move around, or even exercise, or even take the full inflammatory dose of NSAIDs. Rest may aggravate the pain or may not improve it. So these are basically characteristics of patients who have actually inflammatory back pain. But as I said, these are not written in black and white, not engraved in stones. The more the patient has these characteristics, the more likely they have increased post-test probability. So it's important to take history. It's important to document that in your notes. So this is a character difference between inflammatory and mechanical. As I said, the inflammatory, usually the pain lasts more than 30 minutes or even more than 60 minutes in some instances, especially in the morning, often improves throughout the day. And the activity improves symptoms, and it's usually chronic and usually less than 40, and some people say 45. But the mechanical back pain typically lasts less than 45 minutes in the morning, often worsens throughout the day. Activity worsens the symptoms. It can be acute, especially if you hold something heavy and get disc prolapse or a ligament injury or muscle spasm, or can be chronic as well. And usually age of onset less than more than 40 years. So the new concept of spondyloarthritis. So spondyloarthritis, basically the hallmark of it is inflammatory back pain. So this is the new concept. It depends if the patient predominantly complains of axial symptoms, so back pain symptoms, or predominantly peripheral manifestations. If the patients have predominantly axial symptoms, then two diseases encompass that: the non-radiographic axial spondylitis and the classic radiographic ankylosing spondylitis, the one we talk about it more in males, X-ray changes, and all these things. And if the patient presents predominantly with peripheral manifestations, then these include the following diseases: reactive arthritis, especially after viral infection or bacterial infection. Within 4 weeks of infection, then they start to have oligoarthritis, maybe monoarthritis, and maybe some skin changes like what's the name? Actually, I'm just blanking. That thing comes in the palm and hands, psoriasiform lesions, cercinata balanitis in the genital areas, and so on. Psoriatic arthritis is one of the prototypes of the predominantly peripheral spondyloarthritis. Arthritis associated with inflammatory bowel disease like Crohn's disease or ulcerative colitis. And finally, if we don't know where to put patients in which category, we just call them undifferentiated spondyloarthritis. For example, patient with only dactylitis, or maybe patient with dactylitis and family history of inflammatory bowel disease or psoriasis and something like that. That we know that these patients may have a high likelihood of developing future peripheral spondyloarthritis. It's just we don't know where to put them at this beginning. So those patients require time to follow up in the same clinic with the same consultant, not jumping around as most of our patients unfortunately do, especially in the Gulf. So another question comes is, what are the symptoms suggesting spondylitis? We mentioned a lot of it, but what about extraaxial problem? So these are the spondyloarthritis that covers a group of inflammatory musculoskeletal disorders, including psoriatic arthritis, axial spondyloarthritis. And if the patient is coming with axial manifestations, as I mentioned in my previous slides, these encompass axial spondylitis, which is basically the radiographic form, the ankylosing spondylitis form, or the non-radiographic axial SPA. We call it non-radiographic, meaning it's not showing an X-ray. It's just maybe MRI, maybe clinical features, maybe HLA-B27 positive. And a part of the axial syndrome may patient present with inflammatory bowel disease as well and back pain. Reactive arthritis, as I mentioned earlier, patients may present with peripheral arthritis, but may also present with axial problems. Now, the mostly peripheral manifestations are the prototype is psoriatic arthritis, but as I said, some patients with IBD, some patients with reactive arthritis may have peripheral manifestations, and enteropathic arthritis may also have some peripheral manifestations. And then finally, undifferentiated peripheral SPA is when we don't know where to categorize patients. So spondyloarthritis is characterized by diverse clinical and extramusculoskeletal manifestations with varying prevalence. So you have, for example, spinal involvement, especially in the axial SPA, and minority, they have psoriatic arthritis. The peripheral arthritis here, its prototype is the psoriatic arthritis. Dactylitis, minority of patients, like 6%, will have axial spondyloarthritis. Maybe 16 to about 50% of psoriatic arthritis will manifest with dactylitis. Enthesitis is basically where the inflammation of the ligament attached to the bone is, and the most common site is the calcaneal area, is the basically Achilles enthesitis. So patients may actually have they may have plantar fasciitis or Achilles enthesitis. So they will have similar symptoms, basically pain when they wake up in the middle, when they wake up in the morning, and pain is worse when you stand up and try to walk, but then becomes better. Only physical exam will actually differentiate between Achilles enthesitis and plantar fasciitis. And inflammatory bowel disease as well, uveitis, psoriasis, and nail psoriasis. These are the manifestations, as I said, with varying prevalence, depends on the characteristic, on the main disease, actually. Question, what is the burden of spondylitis on patients? So physical and psychological burden of spondylitis is patients will suffer from fatigue, they're feeling discomfort, adaptation and coping problems, work disability, anxiety, sleep disturbance, low quality of life, body image or self-consciousness, physical dysfunctioning, disrupting family and social life, debilitating symptoms, pain, very important. And that's what number one issue patients suffer from, and they really want a treatment to reduce the pain. And then obviously some psychiatric diseases because of the chronic pain that would be, for example, depression. So question, what should I do if I suspect spondylitis in my clinic? Then this is the ASAS recommendations for early referral of patients with suspected axial spondylitis. The ASAS is the largest organization with spondyloarthritis. So patients with chronic back pain with 3 months or more with back pain onset before 45 years of age should be referred to a rheumatologist if one or more of the following parameters is present. Inflammatory back pain, and I showed you all the characteristics, positive HLA-B27. If you as an internal medicine or family medicine or any type of physicians know that this patient has positive HLA-B27, this is a very good chance for you to do some basic tests like X-rays. So you can do an X-ray of the lumbosacral AP view and lateral view. You can do an MRI, but please mention to the radiologist, MRI, look at the spondylitis. Otherwise, the radiologist will do the orthopedic protocol, which will eliminate the STIR sequence. Something called STIR, capital letter S-T-I-R, STIR sequence. So if the patients have peripheral manifestations, in particular arthritis, enthesitis, or dactylitis, dactylitis comes from Greek word dactos, which means sausage shape. Extra-articular manifestations such as psoriasis, inflammatory bowel disease like Crohn's disease or ulcerative colitis, and or uveitis. Family history of spondyloarthropathies, the ones we mentioned, like psoriasis, inflammatory bowel disease, and or uveitis. Good response to NSAIDs, and better to say anti-inflammatory dose. So as a family physician or internist, you must know the doses. So for example, naproxen 500 milligrams twice a day, etoricoxib 90 milligrams once a day, and so on. Elevated acute phase reactants, but not attributed to other causes like infection or high ESR or pregnancy, such as the ESR will go up in pregnancy. So if you have any of those, one or two of the following, and patients have a chronic back pain lasting 3 months or more before the age of onset 45, then please do some basic tests and X-rays, maybe MRI, and then you can refer patients to us while giving the patient an NSAID, full dose of anti-inflammatory NSAID. Another question. So after I refer a patient with suspected spondylitis to your clinic, my clinic, what do you do? Then this is what we do. Diagnostic evaluations. And always starts like a medical student with patient history, physical examination, lab testing, and imaging studies. There is no gold standard for a spondyloarthritis. Maybe most of rheumatology disease, we don't have that. We always go back to the basics that we learned in medical school. So no single test to diagnose ankylosing spondylitis. So what do? We take detailed history. That we listen to the characteristics of inflammatory back pain. We ask about peripheral arthritis, swelling, pain, nocturnal pain, morning stiffness, duration, history of symptoms of dactylitis. Okay, extra-articular symptoms like psoriasis, uveitis, inflammatory bowel disease. You ask and you document. I am very intrigued that many physicians don't document these things. You must document them. If you don't document them legally, you did not ask them. So, and then we do special tests in our clinic, and not all rheumatologists do that. Most rheumatologists do the simple ones, but in our clinic, at least in Taiwan, we do the full ones, assuming the patient has highly likelihood of spondylitis, not every single one. So we look at the neck. We assess the wide occiput to wall distance, as you see abnormality on the picture I showed. Then we assess the tragus to wall distance, and we look if it's wide. So the occiput to wall distance is supposed to be 0, and the tragus to wall distance is about 11 to 12 centimeters. We look at the cervical rotation bilaterally, and we look at restrictions, and you will see, especially in men, that there are a lot of restrictions because of the facet joint ankylosis that you can see on X-ray, or they can because of the syndesmophytes. So we look at the other measurements of spinal mobility, the metrology. We look at chest expansion. At the level of the xiphisternum, we ask the patient to take a deep breath and then breathe out. And then we take the measurement and difference, the best difference out of 3 attempts, and then we mark them. And usually we say less than 5 centimeter chest expansion may be significant. And finally, we look at the lumbar flexion. We have the anterior flexion. There are two tests. We can do middle finger to floor distance just for follow-up and to see whether your intervention was effective in the future. Or we do the Schober, modified Schober test. This is a patient, a real patient of mine with restricted lumbar flexion. He was unable to pray, to kneel actually while he was praying. So there are two types actually. I don't expect internists to do it, although it actually comes in the exam, whether it's Arab board exam or the Canadian board or whatever. So people, as an internist, you must know this, how to do the modified Schober. But nowadays with other features, you may want to give a big picture and say, okay, this patient is unable to do full flexion, anterior flexion, then maybe I'll do some test here and there. We do a lateral lumbar flexion as well, and this is normal in this patient. But in many patients, it's less than 10 centimeter difference between the middle finger while you are standing and while you're laterally bending. So that would be less than 10 centimeter is actually significant for restriction. We also do other measures like intermalleolar distance, and we do internal hip rotation distance, which gives an idea if there is a hip problem or if there is a enthesitis, adductor enthesitis problem. But these are sophisticated tests you don't need to know as an internist or family physician. I'm just showing you what we do in our clinic. Peripheral features, we look at dactylitis, as I said, sausage finger, highly characteristic and highly specific feature of spondylitis. Painful and diffuse swelling of the entire digit. It can be acute, it can be chronic. Keeping in mind as an internist, there are other causes of dactylitis like sickle cell anemia, sarcoidosis, among other causes. So we do the peripheral manifestations. We also look at enthesitis, and the most common is the heel. If you send me a referral with at least you did check the heels, looking at plantar fasciitis, looking at Achilles enthesitis, or maybe Achilles tendonitis, that's for me is enough. But there are many types of the enthesitis in the human body, depending on the measure that you use, and you don't need to know that. Tests, we talked about acute phase reactance, CRP, and high CRP is considered a feature of axial spondylitis, assuming there are no other causes, no infection or no trauma or any other cause that may increase the C-reactive protein. ESR can be elevated, but not in every single patient with spondylitis. We do HLA-B27 with high sensitivity and specificity and likelihood ratio, but most of the time, the lucky patients are the Caucasians. The Arabs are not that lucky. We don't have this gene commonly in Arab patients with spondylitis or patients with psoriatic arthritis. So that's unlucky for us. I mean, we have to find another gene for Arabic populations. X-rays is superior to MRI in detection of ankylosis and syndesmophytes. Syndesmophytes are basic calcification of anterior intervertebral ligaments. It cannot detect early inflammation of ankylosing spondylitis. That's why the MRI came to being. So this is the X-ray. The first one is A, is the normal X-ray. It would be nice for our internists and family physicians to train their eyes on how to look at normal X-ray. First of all, you have to order either pelvic X-ray with hips. It's actually for patients, for people who work in Abu Dhabi, it's actually in Saha orders. It says hips with pelvis X-rays. It basically will show you the whole hip and the pelvis. Sorry, the whole hip, pelvis and both hips. Why? Because some patients may have bad hip osteoarthritis, and these tend to be young patients. So this A or subset A X-ray is normal, black from top to bottom, which basically tells you the cartilage is unseen because it's not calcified, because there is no decrease in like erosion or decrease in area. Look at the B X-ray. Now you can see the black line is not, the black line is not clear. There is like a right bite here. Something is eating it. It's erosion. And if you look here also, there is some calcification. Now look at C, you can see that the distance is narrowing more and more with some sclerosis on the sides. And maybe there will be some ankylosis, total fusion, but may not be seen clearly in X-rays, better on MRI or CT scan. Now you look at the last stage, we call it ankylosis, which means in the ancient language, total fusion. You cannot see the black line. There is no more cartilage, bye-bye. So this is the late stage of ankylosing. A reminder, not all patients with spondyloarthritis will reach this stage. So the name is actually a misnomer. It's in 40% of patients, there will be ankylosis, but in 60%, there will not be ankylosis. So it's unfortunately a name for a scary stage 4, which only happens in some patients. In MRI, if you look at the MRI, it visualizes both acute and chronic inflammatory changes of sacroiliac joints and spine, resulting in early detection of sacroiliitis and ankylosing spondylitis. If you can look at this MRI with stair sequence, you can see bone marrow edema, which are basically the arrows indicating active bilateral sacroiliitis. So it requires a very good radiologist. It requires a proper MRI. Okay, so you require 2 things. Like many radiologists, they actually don't know how to diagnose this and they overcall this. So we have to, as rheumatologists, we look at the MRI and may have a meeting with our radiologist and say whether this is actually a bone marrow changes or white lines, white area on stair sequence. So better to see stair sequence, but you can have T2 fat sat as well. But it requires a very good radiologist, a very good internist, our rheumatologist as well. And interpreting all this in the context of symptoms, not just randomly interpreting that. You have to have some history. So the old classification criteria is called Modified New York Criteria for ankylosing spondylitis. It's basically 1984. That was very strict. They really require a clinical criteria and X-ray. That's why radiographic. That's why it's ankylosing spondylitis. So the clinical feature require minimum of 1, low back pain and stiffness for more than 3 months, which improves exercise, but not really rest. Limitation of motion of the lumbar spine in both the sagittal and frontal planes. Limitation of chest expansion relative to normal values correlated to age for age and sex. But you require 1 of this, but 1 X-ray changes, which is sacroiliitis grade 2 or more bilaterally or grade 3 or 4 unilaterally. And that requires a very good radiologist and or rheumatologist. But we have MRI, we have HLA-B27, we have other features. So this criteria is very strict. It tells you there is a subset of patients with actually clear, definitive ankylosing spondylitis. But unfortunately, it eliminates many patients who suffer the same. So now comes the new classification criteria for axial spondyloarthritis or ASAS organization. It requires the entry criterion that patients more than 3 months or more of back pain and age of onset less than 45 either will go to the clinical arm, HLA-B27, plus 2 or more of the spondylitis features, or the imaging arm, sacroiliitis and imaging. This time they said MRI or X-ray, not just X-ray, plus 1 or more of spondylitis features. So the imaging arm is stronger. But the problem, nothing is coming without any disadvantages. You have to have an MRI, proper an excellent experienced rheumatologist and or radiologist. So what are the SPA features in this classification criteria? Basically, inflammatory back pain, arthritis, epiphyseal, especially heel, uveitis, dactylitis, psoriasis, inflammatory bowel disease, good response to NSAIDs, family history of spondyloarthritis, HLA-B27 positivity, and elevated CRP. So you see, you need this criteria. But the problem with physicians that they rely on this for diagnostic purpose, and you shouldn't do that. These are classification criteria. These are basically for testing incidence and prevalence of spondyloarthritis. If you want to speak the same language in the UAE as people in Egypt, as the people in Australia, then these are the classification criteria that patients should be diagnosed first by a rheumatologist, and then this criteria should be applied. And then we talk about incidence and prevalence. Or this criteria is used for testing the effect of patients with a new randomized control trial of a new drug. And we want to collect and recruit patients with similar characteristics. So again, these classification criteria in general are used for epidemiological studies, should not be used for diagnostic study. Therefore, in the rheumatology world, we do not have diagnostic criteria. And that's some problems with many rheumatologists, many internists, many other physicians don't understand the difference. Unless there is a study to show that the classification criteria can be used as diagnostic, then you should not use it as diagnostic. Very important concept, actually. The recommendations, I'm not going to go into details to people, but just a big picture. Recommendations for management of axial spondylitis usually starts with education, exercise, physical therapy, rehabilitation, and assuming you have a very good rehabilitation center, which we don't, by the way, we need to, that's an unmet need in the Gulf area, that we do not have a great rehabilitation center for patients with spondylitis. They just do open the internet and try to use whatever method is there, or try to use their experience, and that's wrong. We've seen that with our own eyes. I'm sorry, I'm being honest, but we do not have good rehabilitation center. We have, that's something we have to develop in the near future if we want the best for our spondylitis patients. Patient associations can be helping, self-help groups, but NSAIDs can be used and cheap. You can try them first, and they retard the progression, radiographic progressions, has been shown in studies. If patients with axial disease, NSAIDs would be helpful. Patients with peripheral disease, if they are mild, NSAIDs would be helpful. And sulfasalazine would be helpful more with peripheral manifestations. And local steroids can be tried. But basically, biologics and JAK inhibitors, I'm sorry, there is a typo. A JAK inhibitor, they are basically new oral agents. These two classes of drugs can be used for both peripheral and axial. And I'm not going to bore you with, but basically, we leave this decision to the rheumatologist. Analgesia, if there is chronic pain, surgery, and now surgeries are being discouraged only in selected cases. And this is the big picture of how to manage patients with axial spondyloarthritis. Quickly, I'm going to go through this in the next couple of minutes. TNF inhibitors basically are subcutaneous injections like etanercept or Imbral, the originator, we call it, the original drugs, adalimumab like Humira or Amgevita, and now we have Hyrimoz, basically biological originators or biosimilars. Certolizumab, golimumab, IV infusions like infliximab. We have 3, Remicade, the original drug, and then we have the biosimilars like Exify and Remsimab. We have golimumab, which no one is using it except in Taiwan, and I stopped using it because unavailability. We have the non-TNF inhibitors like secukinumab or exekizumab, oral disease-modifying antirheumatic drugs or DMARDs like sulfasalazine, methotrexate, and leflunomide, upadacitinib is the new JAK inhibitor, and the tofacitinib or Xeljanz is the new, newly approved. So these are the big picture of the biologics and oral JAK inhibitors. But the big picture also says that because of the multi-systemic involvement, you need multidisciplinary approach and proper referral to our patients, for our patients. So you can ask a referral to dermatology clinic if there is psoriasis, or gastro clinic if there is inflammatory bowel disease, pain clinic if there is ongoing chronic pain, ophthalmology clinic if there is uveitis, ortho clinic if you think the patient will benefit from hip replacement, and family medicine and internal medicine clinic, which we're going to talk about that in a second. So what should I do if I suspect spondylitis in my clinic? This is actually the internist or family physician. You can test some tests, actually, you can order some tests, HLA-B27, like the diagnosis of ankylosing spondylitis, ICD-10 code M45.0, to minimize insurance denial. You order routine blood tests, say CBC, creatinine, LFT, and inflammatory markers like CRP and ESR. You order x-rays of the painful area and write a comment to radiology, chronic back pain, please assess for spondylitis and degenerative disease. And these are the x-rays that you may want to order. Cervical, 2 views. Lumbosacral spine, 2 views. Pelvis x-rays with hips. So these are the important things you will see on Cerner or the electronic medical record in the Sahha hospitals. How can an internist help in co-manage spondylitis patients? The co-management by family or internal medicine physicians, basically vaccinations, especially inactivated vaccines, pneumococcus 13-valent if not given previously, then pneumococcus 23-valent after at least 8 weeks. Annual influenza vaccine, hepatitis B vaccine, and first order Hep B surface antibody, surface antigen, core antibody. If they are negative, then you give Hep B vaccine. And some physicians give 20 microgram, and some recommendation is to give 40 microgram because patients who may get a concomitant intake of immunosuppressive, then better to get the higher dose. COVID-19 inactivated vaccine obviously is no problem. Then you also do a cardiovascular assessment like diabetes mellitus, hypertension, hyperlipidemia, hyperuricemia, sleep apnea, heart disease, chronic renal disease, smoking, and alcohol intake. It's really very useful if an internist and family physician helps us rheumatologists with the cardiovascular risk assessment and obviously intervention. Other related issues like psychological support, referral to pain clinic, referral to GI clinic, ophthalmology clinic, derma clinic, if extra-articular symptoms appear. And this is basically how you as an internist or family physician co-manage patients with spondylitis with us. I'm looking at the time to just to check, I'm getting close to the end. How do you follow patients with spondylitis? We basically follow them up after intervention, whether it's non-pharmacological and pharmacological. We assess the drug adherence, administer questionnaires to assess disease activity, functional limitations, work productivity, quality of life, patient global assessment, etc. Ask if another family member has psoriasis, IBD, spondylitis, or uveitis, because the story may evolve. Physical exam, we do spinal mobility measurement, tender joints, swollen joints, number of dactylitis, number of enthesitis, signs of psoriasis. We do other tests like routine blood tests, especially inflammatory markers, and X-ray, neck, lumbosacral, pelvis with hips every 2 years to see radiographic progression. What are the challenges that you face in diagnosis and management of spondylitis patients? The delay in diagnosis by 5 to 11 years, because the patients begin with non-radiographic stage with back pain, may or may not be seen on an MRI, but then some of them, 40% of them will transform into the radiographic sacroiliitis and maybe syndesmophytes, and these takes years. Also, there will be delay in diagnosis. These are the data from real world that shows you that in patients with ankylosing spondylitis, a mean diagnostic delay of 8.6 years has been observed. That's why you're here to listen to us so that you can do some simple evaluation before referring patients to us. This is a natural course of classic ankylosing spondylitis patients, and you do not want your patients to reach that stage, unfortunately, with stooped shoulder and hip flexion contraction. I guess this is not important. If my patient who is on immunomodulator drugs presents to my clinic with infection, what should I do? These are my personal recommendations. Treat the patient with antibiotics when deemed necessary. Check drug-drug interaction, especially if the patient is on immunosuppressive drugs like methotrexate, sulfasalazine, any of the JAK inhibitors like upadacitinib. Communicate with the treating rheumatologist via telephone or email for an update about patient's condition. Delay next injection of biologic drug until the infection resolves, and follow up patient after completing course of antibiotics. And I don't know, Abdullah, we have time for cases or we're done?
We still have 2 minutes, doctor.
2 minutes, khalas, I'll finish. So we have a quick case here about non-radiographic axial SPA. 20-year-old Emirati man, single, has negative HLA-B27 ankylosing spondylitis based on inflammatory back pain since the age of 17, polyarthralgia, 16 enthesitis on physical examination. X-rays was showing in September 2019, the lumbosacral, no signs of spondylitis, meaning no squaring of vertebral bodies, no syndesmophytes, no facet joint ankylosis, no shiny corners. But there was loss of lumbar lordosis, indicating spasm. Pelvis with hips were normal. Normal hips, normal SI joints, sacroiliac joints. But the MRI in 2019 did show something. Showed fatty infiltration on the iliac side of the sacroiliac joints bilaterally. The radiologist thought it could be normal, but we thought fatty infiltration unusual in a young man. Bone marrow edema on iliac side of right sacroiliac joints seen on stir sequence in T2 fat sac, suggestive of right sacroiliitis. No joint space narrowing or erosion, which is good. Only inflammations for the time being. So we diagnosed with organographic axial SPA. We actually following him over time. These are the table I do in my clinic. It's basically looking at disease activity index we call BASDI, functional index we call BASFI, CRP, as that CRP, an equation, you don't need to know about it, but just an equation to tell us the activity and enthesitis. So in September 2019, his number were high. The CRP was normal. See, he's one of those patients with the normal CRP, but 40% of patients would have high CRP, but these one of the 60% of patients. Enthesitis 16, that's a lot. So we gave him interleukin 17 inhibitor, and then things became better over time, but then he became worse, unfortunately. We looked at the MRI to September 2020, no signs of spondylitis in the neck area, lumbosacral, no change, and the pelvis X-rays also no change. So this, unfortunately, this is the X-rays, but the MRI still show persistence of sacroiliitis. This time there is also on the left side. And then we did an MRI of the spine and it shows some shiny corners of anterior, superior in place and the anterior inferior end place at L5, which basically is spondylitis, inflammation. So what did we do? We changed him to a biosimilar, cheaper version of the biological originator. It's adalimumab biosimilar, we call Angivita, and improved, but and then he got worse. So we said, okay, we stopped Angivita and then the biologics, and then we did optimize his NSAIDs dose and physiotherapy. Still symptoms got worse. We agreed to replace Angivita with a new drug, oral JAK inhibitor approved this year or last year actually. It's called Rinvoq or oparacetinib. He has been taking since 3rd of May 2021, and he did very well with that. You see our struggle. Some patients do well at the beginning and then do keep getting worse until we find the proper solution for those patients. I guess with this case, I'm gonna stop here. Yeah.
Thank you very much, Dr. Khalid. Very detailed lecture. Thank you for your time. Dr. Fahad may join us back for questions, and so I will alternate questions between you, Dr. Khalid, and Dr. Fahad. I will start with Dr. Khalid since you just finished. Dr. Khalid, if your patient, ankylosing spondylitis, you know, most common presentation is back pain. He come to you, you started his medication. He asks you this question, can I go to do acupuncture, or can I go to do massage, or would you recommend me just to go with a professional physiotherapy? From your clinical experience, Dr. Khalid, would you recommend your patient to do so?
I need to know if this patient has some kind of, I need to know the bone health. And some patients may have some osteoporosis, unfortunately, osteopenia or low bone mass. I need to know if there's some if there is syndesmophysis and too much of fusion. If that's the case, then they need to be careful with the physiotherapist or massage therapist. I'm not aware about acupuncture, but it can be used for chronic pain. It's just, I'm more worried about the massage or chiropractor, because these people can crack something, and the patient actually, there was a case report, a patient went with ankylosing spondylitis and he cracked something because the chiropractor tends to vigorously hold the spine in a certain ways. You have to be very careful with that actually. Those patients also may have problems with going to the dentist or to having an operation, because they are usually fused, and you have to be careful when you extend the knee actually or flex the knee. So being careful actually, and knowing the baseline of the patient, its X-ray findings and all that will be important determinant.
Okay, thank you, Dr. Khalid. Another second question is for Dr. Fahad. This is from the audience. The question is, what's the value of repeating anti-CCP test? And the second part of the question is, what's the value of repeating ANA, anti-double strand DNA, and C3 and C4 in lupus patient on treatment?
Well, with regards to the first one for the anti-CCP, I don't recommend doing repeat anti-CCP or rheumatoid factors. So if somebody has had a previous positive rheumatoid factor or anti-CCP, then you know that they are seropositive. There is no role to repeat them for disease monitoring purpose, because the monitoring is with clinical monitoring plus inflammatory markers monitoring. Patients who are seronegative to begin with, and they don't have a clear-cut diagnosis. So in those patients who you can repeat them maybe after 6 months or 1 year, because as I said that 50% of the patients are negative to start with, but about 1/3 remain negative throughout their life. So that means that some of these patients who are seronegative in the beginning, they may become seropositive later on. So it's useful in those patients who are negative to start, but not useful who are already positive. So with regards to the ANA and double-stranded DNA, we don't do them very routinely after the initial diagnosis. Complements, they are checked in the beginning to know whether they are low or not, because that suggests that they have got an active disease. I personally repeat them only if I think that the patient is having a disease flare up. So it helps us in seeing whether their anti-double-stranded DNA titer is going up or their complements, if they are previously normal, now they have decreased. Then they may suggest that there is some internal organ involvement going on. So routinely after the diagnosis, no, there is no role. So recheck them if there is a change in patient's clinical condition.
Yeah, thank you, Doctor. So another question for Dr. Khalid. If your patient with ankylosing spondylitis presented to ER with severe back pain or joint pain, does NSAID still the first line treatment, or opioids has a role in ER for such a patient?
I think this question was asked in previous, I remember that question vividly. The way I answered it is the same. If the patient presents with back pain, we're talking about the cause. So why was there acute back pain? Is it a flare or is it a fracture? So having a simple X-ray to determine if there is a fracture would be useful. If the patient is known to have spondylitis and stop the medication somehow, or then NSAID would be the main therapy here, just to go the acute phase. And it's better to give it intramuscular like Voltaren, 75 milligram. I don't know if you have more to be useful. That's the way. I think it all depends on the cause. Opioids, I'm not sure. It depends. You can give opioids in any case, but I try to avoid opioids, because the opioids themselves, they have some side effects.
Okay, thank you, Dr. Khalid. For Dr. Fahad, some medication can increase uric acid. For example, anti-TB medication also can increase to a very high level without the joint pain. Is there any indication for urate lowering medication?
Well, not from the joint pain point of view. So if somebody does not have a gout, from the rheumatology point of view, so there is no point in giving them a urate lowering medication, but they may have some other indications. And then recently there is a paper on chronic kidney disease patients who have hyperuricemia. So some of those patients, especially with the proteinuria, they may benefit from urate lowering therapy. So from the rheumatology point of view, asymptomatic hyperuricemia, there is no need to treat unless there is some other comorbidity like chronic kidney disease or kidney stones, uric acid kidney stones, which needs treatment.
Thank you, Doctor. Maybe this is the last question for Dr. Khalid, and after that we will end the webinar. The question for you, Dr. Khalid, is there any suspected etiology other than genetics? And if yes, why it affects the Arabs who has no HLA-B27?
No one knows, unfortunately. We know HLA-B27 one of the implicating factors, but there are other epigenetic causes. There is something called ERAP, ERAP. There is one of the interleukins also. No one knows exactly the full mechanism. We have a lot of theories, but we know we can implicate some of the things. But Arabs, we don't know. We discussed it many times in many meetings, and no one knows. It just requires some money. If we have some funding, we'll get some blood from Arabs, and then we'll try to map them to different HLAs and maybe other non-HLA things like ERAP or interleukins, and see which one is more associated with these diseases. But you have to ensure that these cases actually do have spondylitis, whether it's X-ray or MRI and other many features. So it requires a study. No one knows for sure, unfortunately.
Thank you very much, Dr. Khalid. Thank you for your time. Dr. Fahad, thank you for joining us tonight. I would like to thank the audience for being with us. Now we will end the educational webinar. Thank you very much for your time.
Thank you. Thank you very much. Bye-bye.